Welcome, everyone. It's good to be here. I'm not going to spend a lot of time talking because we got a lot to cover, and I think everybody probably just wants to get into it. So my name's Chris Ray. I'm the Associate Director for ATSDR.
I'm Ari Bernstein, Director of ATSDR and CH. I'll be presenting in a minute.
I'm Tara Summers. I'm the Regional Director for ATSDR Region 1.
And I'm Harriet Silverman. I'm Senior Advisor to the Director.
Well, welcome, everyone. It's good to be here. Like I said, we've got a lot to cover. We're going to talk about the PFAS study report, and Dr. Marian Povich from ATSDR will be leading that discussion, and he is online. And then Dr. Bernstein's going to talk about our PFAS information for clinicians. Then we'll have a Q&A and then talk about next steps. And then Laurel's going to talk a little bit about the PFAS REACH study. So without further ado.
Thank you, Dr. Rare. Good evening, everyone. Thank you for joining me here to learn more about the PEACE study that we've been working and preparing since 2018. And this will cover design methods and cohort description for this effort that ATSDR funded and conducted in PEACE community. We'll be I'll be talking briefly about the background of the site and PEACE, and cover study overview, a little bit design, and then talk about the cohort demographics, then about PFAS concentrations at PEACE, also comparisons with US general population as described at NIH's survey, and also touched a little bit on the reported health outcomes at the PEACE study, and provide some key summaries and points on those results, and then we'll open for questions. We can get back on the slides that you see. I have also some additional information, and we can also return back to some slides that you may be interested in to see again. Next one, please. I would really like to extend our thanks on behalf of all the study team and people at ATSDR that worked on the study, to PEACE study participants. This is a large and complex undertaking. Participants took a lot of time answering our questions on the questionnaires. They had to provide blood and urine at the study office, and those that participated with their children, they spend even longer time doing the neurobehavioral assessment in the study. So we really extend our deep thanks for their time and efforts of being part of this undertaking. And this would not have happened without the close and long-term involvement of all the community assistant panel members. Many of them are here tonight. Many late evenings at PEACE over the years, going through study approvals and preparations, and then recruitment through the COVID before and after. So this extends to all other community members that helped with many aspects of letting people in the community know about the study, about trying to participate, and getting them in the study. And as you know, we have enrolled over 1,000 people in the study, which I'll talk about later. So I think it was a great undertaking, and I wanted to acknowledge that. I will acknowledge my ATSDR colleagues during the slides and the results that we'll present. I just want to highlight the efforts of Frank Bobby and former director, Dr. Patrick Bricey, that were instrumental in getting this on the road and preparing feasibility analysis, and working on getting the funding for this study and for the multi-site study. And also external partners, APT associates that were our face in the community, manning the study office and the labs at the CDC, the LS, Antonio Califat, and also the LabCorp and SUNY. And last but not least, the New Hampshire Division of the Department of Health and Human Services. Thank you. Next slide, please. So we are here because of the PFAS chemicals. The large group of synthetic products that has been used, developed and used by the industry for almost 70 years because of their properties to resist oils and waters, and in number of industrial and consumer applications. The per and polyfluoroalkyl substances that you see here are the most commonly studied and formerly produced, PFOA and PFOS, perfluorooctane sulfonate. Those are with 8 fluorines and are no longer produced. And the other commonly studied, like PFHXS and PFNA, were also part of some of the firefighters' foams that I'll talk later. Next one, please. I think we can slip. Can we go to the next slide, and then we'll return to this one. As I mentioned, the very properties that made PFAS interesting from the point of view of industrial uses and consumer uses also unfortunately led to the environmental issues and problems, because they're hard to break down and they stay in environmental matrices, whether it's water or soil or food. As I mentioned, the contamination results from the use in industrial processes, whether their production or the use in materials and fabrics and consumer effects that are used with the use of PFAS, and also around number of former military installations, airports and bases, where PFAS were used as part of foam used for battling the fires and training exercises at those airports. The previous slide, please. So the PFAS has been intensely studied over the last 15 years at least. Center for Disease Control and Prevention lab has measured PFAS for the first time in 1999, 2000 in Haines. I think it was 2004 or 5 and that it was published. And there's a growing large body of literature now that looked at number of health outcomes, and some of those have been associated with PFAS more than the others. There's a number of cardiometabolic outcomes, like increased level in cholesterol levels. That's probably the most commonly reported and most consistent outcome in human health studies. There's also changes in liver enzymes for a number of PFAS analytes, and also not in this slide, but there's a number of reports also on thyroid outcomes. And as you see here, from larger studies on workers and on participants in studies that lived around former production facilities, we had results on kidney and testicular cancers, and also the findings of lower antibody response to some vaccines. And there are some neurodevelopmental and neurodevelopmental issues, like small decreases in birth weight in newborns, and pregnancy-related outcomes such as hypertension and preeclampsia. Next one, please. Next one. So just to step back, we'll be talking about the PEACE study, but just a little bit in a context of what ATSDR does in a larger group of activities on PFAS. The PEACE was really the first site for the larger multi-site study that were conducted through 2021, 2023, at 7 additional sites to PEACE. And we were looking to, the study was designed to really expand and evaluate the health outcomes related to drinking water exposures contaminated with PFAS. ATSDR also before or during the conduct of PEACE study also conducted exposure assessment at 10 additional sites of the former, mostly former military bases. Next one, please. So getting to the PEACE site, you know the site probably better than me, although I have visited a number of times, but still a visitor. PEACE, as for Air Force based as other military airports and installations and regular airports, use the aqueous film forming foam, so-called Class B, that uses flammable hydrocarbons. That one does include a small amounts of PFAS, PFOA, PFHXS. Unfortunately, those molecules migrate through soils and into groundwater or surface water sources and contaminate those. The PEACE for Air Force Base closed in 1991, was converted to PEACE International Trade Port, and being on the base and drinking water on the base was part of the eligibility criteria for the study. Next one. You remember in May 2014, the measurements in those wells at PEACE had found elevated levels for number of PFAS analytes, and which exceeded quite a bit the EPA advisory levels at the time. I think it was about 2.4 microgram per milliliter at the time in water. Consequently, the well was closed and filters installed to get those levels below. And a biomonitoring program was implemented that time at New Hampshire Department of Health, and a number of residents participated in that program during that time period, and was also part of our PEACE recruitment strategy. The result at that time, published by Daly 2018, was that serum PFAS, PFOA, and mostly PFHXS concentration were found to be elevated in both adults and children. Next slide, please. So that was one of the stimuli for setting up a PEACE study and multi-site study that look at health outcomes related to PFAS. And the PEACE was the first site of multi-site study. We have developed the protocol and study instruments, questionnaires, and procedures for collecting blood that were later implemented at all the multi-site sites. The study, which aimed to be fairly large, I mean, we're looking at almost over 6,000 people for multi-site study that I'll touch on later, still focus mostly on non-cancer health outcomes of PFAS exposure. Next one, please. The data collection, as I mentioned, was quite complex. It included basic health information such as body measurements and measurements of blood pressure. We have collected blood and urine samples from participants, and all participants, including children, answered a structured questionnaire with medical, social, and family history. We also ask detailed questions about their current medications, and as I mentioned, some children participants underwent a fairly lengthy neuro behavioral assessment. So it was a fairly extensive assessment for adults and children that took time of the participants. Next one, please. So overall, we started recruitment in 2019. We developed the protocol and got CDC IRB approvals and OMB approvals in May 2019 and started in October and completed in December 2021. We had to stop enrollment due to COVID in March 2020 and restarted then later slowly in November 2020 in person. We have switched the questionnaires mostly to phone questionnaires to reduce the amount of time that participants spend in study office. So we have screened over 1,400 community members, almost over 1,100 were eligible. They had to live in the Peace or Newington area and drink water at Peace, and people that were exposed to PFAS occupationally were not eligible to be part of the study. So in total, we had 776 adults and 180 children that completed questionnaires and provided blood for PFAS analysis. And out of those 180 children, we had 128 that completed neurobehavioral assessment. Next one, please. Overall, we had fairly balanced samples, almost 48% male for adults, more for children. The group was mostly middle age, 50% 40 to 59 years old, and over 30% over 60 years old. Most of the children were in the 6 to 11 year category. The sample is predominantly white, non-Hispanic. Next one, please. Has fairly high educational level. Over 50% of people have a university college degree, and over another additional 26% graduate or higher college education. And more than a third of the people are in higher income category for adults, and almost half of those for kids. Next one, please. As there's almost complete health insurance coverage in this community, and as the water contamination was discovered, people didn't use Peace public water system and also switched from the contaminated wells in Newington. And as you can see, there's other wells used and other water system used at Peace because of that. Next one, please. So I'll stay a little bit longer on this slide. This is the main results for the PFAS levels at Peace. I don't know if I can move the cursor here, if you can see. On the left, we have Peace participants divided in two subgroups. One that those that consume contaminated water. We also have enrolled a smaller subgroup that would work as referent for those that didn't consume water at Peace, to compare the two groups of people. One is the NHANES is national survey that provides level for non-institutionalized general US population. These results are from 2017-18, fairly close to 2019-20, 21 that we collected at Peace. And the column on the right includes the biomonitoring effort at New Hampshire. So I want to draw your attention to the first column, geometric mean on the exposed people for PFAS. So around 5, and it's 445. Therefore, NHANES, as you can see, that's about 10% higher levels at Peace than at NHANES. For PFOA, it's more, it's almost 30%, and it's about 20% for PFNA in the third line. The largest differences in Peace, similar to findings from New Hampshire biomonitoring, was for PFH-XS, where we see almost 3 times the level at Peace for PFH-XS than in national average for NHANES. So overall, we can see that most of those are still higher than in NHANES. At the same time, you see on the right side the levels for the New Hampshire biomonitoring from 2015 through 18, mostly collected in 2016. you can see there that the levels there were quite higher than the current levels in PEACE. They dropped by about a half, and that's generally a good news for the community, as we see the decreases in NHANES between NHANES 2017-18 and NHANES 2013-14, kind of previous cycle there. We see about 20 to 30% decreases for some of the congeners, and so the decreases at PEACE are higher. They're also partially higher because the level to start with at PEACE were also higher. Okay, next slide, please. So in addition to 4 major congeners that are measured almost in everyone, we have measured higher PFOS. PFOA have 8 fluorines, PFNA 9, and PFHXS 6. On the higher chlorinated, like PFDA, PF1DA, have 10 and 11. MIFOSA is lower chlorinated congener, and you can see that the levels here are not very different from NHANES, and in general, those concentrations are much lower than the congeners in the previous slide. Next one, please. This table shows the levels for children, comparing to NHANES group in 2017-18, 12 to 17. So it's a little broader for PEACE. Again, all the levels for all analytes, PFOS, PFOA, PFNA, PFHXS, not for PFNA here, but for PFOA, PFOS are marginally higher in PEACE than in NHANES, but the difference for PFHXS are almost over 50% higher still than NHANES 2017-18. Just a side note, the cycle for NHANES 2019-20 was interrupted by COVID, so CDC couldn't collect the full sample. Only about 500 people out of 2,000 were enrolled in that NHANES survey, and will be presented later together with 17-18, so they will not be presented separately, so we do not have a closer comparison. Just wanted to know that. Next one, please. So we're getting to the third part of our report, and that is the frequency percents of self-reported and healthcare provider reported health outcomes. Those are sorted by the prevalence here, or by the highest number reported for the participants, and you see what we would expect to see: higher cholesterol, higher blood pressure being reported in over 200 participants, quite a bit of allergies, then following by asthma, atopic dermatitis, then bone diseases, osteoarthritis, osteoporosis, and we also have about 76 thyroid disease and 60 diabetes in this group. Numbers roughly corresponding to the general prevalence in New Hampshire, or what you would see in the community. That was not necessarily the goal of the study. Really, what we want to look at is to contrast those with PFAS levels, which will be the focus of our future analysis and will not be presented here today. Next one. Also, what I want to note, as you see additional health outcomes here that are getting lower for a number of those, like kidney disease or liver disease, we will not be probably analyzing or presenting those data separately for PEACE. What we want to do, as I'll show in future direction and next steps, we want to we'll be aggregating what we're doing right now, aggregating this data with other sites on multi-site study and analyzing, presenting those outcomes together, and with multi-site, a site being one of the sites for the multi-site study. Next slide, please. This is the results for the most reported outcomes for kids. Again, there's some allergies, atopic dermatitis, neurobehavioral problem, attention deficit, and some others. Again, I think I should mention that we have extensive clinical test and biomarkers levels that we have for all 180 kids and 776 adults, or for most of them, not for all of them. There's always some that may not be could not be analyzed for different reasons, but they're a small percentage. So we have those outcomes that we'll be also looking at in those larger numbers. Next one, please. So in the next few slides, I'll just summarize again a little bit what I went through in the individual slides. As I mentioned, we have fairly large numbers that we can look at these for high cholesterol, high blood pressure, that we may be looking here again for things like diabetes or thyroid disease. We may be considering to presenting those together in the scope of multi-site study, and similarly for children. There's over 700 children for the multi-site study, so 180 for PEAS is the largest sub-study of all the sites. Wanted to mention that. Next one, please. So for PFAS levels, I think the results are kind of in line of what would be expected. The PEAS study participants have still higher levels than NHANES results from 2017 for most of the congeners. For biomonitoring, again, we see decreases in all the congeners across the board that are sizable and larger than for NHANES. Next one, please. We have the study really looks at evaluating PFAS from drinking water exposures. That's a strength that the source of the contamination is known at PEAS. The fairly large part of the cohort, provides additional information that we can look on, not only on PFAS, on exposure sites, but also on health outcomes and clinical and research biomarkers. That's also true for the smaller children cohort that will be combined with the other children participants in the multi-sites. And thanks to collaboration with the New Hampshire State Health Department, we also have the levels for the participants on that were part of that effort earlier, and we can look at the changes of how the PFAS change in the same people. Next one. As with all observational studies, we cannot definitely determine that a PFAS level in person is definitely linked to past or current health problems, or do the predictions of whether they mean that future health problems may occur. Given the length of exposure going back, we went as back as 2004, 2014, there may be people do not necessarily recall exactly how much water they have drank at the base, or how much time exactly they spend, although I think the recall on that part, being part of those interviews in 2019 was very good from the participants. Nevertheless, this has little impact on the comparisons presented here, as we have measured levels for PFAS that do not depend on recall. This is more of an issue in historical reconstruction that has been done at PEAS, and will also include that effort in later statistical analysis. Next one. So for the next steps, I have already outlined some of the issues and plans here. The analysis of the health outcomes and the clinical biomarkers to examine the association between the PFAS and health effects is underway. We'll be working on those in the coming years, and we'll plan to present the results at future committee meetings here at Portsmouth. As I mentioned, PEAS, as a sizable cohort as it is, will be combined with and be aggregated with other MSS data. As I mentioned, we have over 5,800 adults and 700 children in the multi-site data set. So that will be that is something that is a great result and testament to interest and resilience of the people to get and participate in this effort. Just to give you an idea of this timeline where we are with multi-site, the enrollment have ended at the end of September of the last year in all sites. So that's done 2023. And we are doing a lot of data management work and preparing a combined data set, merging the piece and multi-site data. And we're hoping to get that done by sometimes end of June, to have some preliminary things, the results from all the labs and results from all the verification of medical records. Those are the issues that take time. Similarly, like and PEACE, we have ended enrollment in 2021, but it took us until March, April of next year to report the results, to complete the analysis of all the PFAS and clinical tests to report to participants, and then another 6 months to prepare the data set with all the information that was there. So similarly, by the end of August, September, we hope to have those data set and share that with our cooperative partners. Next one, please. So, as I said, we'll be working very closely with cooperative partners across multi-site study on statistical analysis of the data and publications of those results, investigating the association between the exposure to PFAS and health effects. So we're very excited to get to this point, to get to data and evaluate the outcomes on PEACE and on PEACE as part of our larger effort. And other sites, also many sites had a similar program as New Hampshire biomonitoring. So we'll be able to conduct some of the analysis on how the exposure changed at different sites across all multi-site sites. Next one. So getting to a close here, there's a number of resources on ATSDR website about exposure assessment reports are all there. There's information on PEACE study, multi-site study, and other resources, and recently released guidance for clinicians that Dr. Bernstein will be talking a little bit later. So I think that closes my presentation. I think we may be open to some time of questions if that is desirable now or later in the meeting. Thank you.
Yeah, let's go ahead and do questions now before we move on to the clinician information brief. So, Brandy, you're looking at whether there's hands raised, right?
I'm looking at the chat right now, and I do have a question that we can start with. It says, why do we not hear more about PFAS causing autoimmune diseases when researchers have linked these chemicals to, quote, lower, affecting, disrupting, and deregulating the immune system? I was enrolled in the study and my subsequent autoimmune disease was on the questionnaire. I self-reported it and it does not show up on the results. Why?
So, can you hear me?
Yes, sir.
So the autoimmune diseases were included on PFAS. You may recall that those are fairly rare. We can go, Brandy, if you can scroll further down. We have captured number of those, and the numbers are low for PEACE. Nevertheless, they'll be further down, please. They will be included in the multi-site study and analyze here. Here are some of those for P's as they're self-reported and providers reported. So I only in the slides and in the presentation, we didn't want to be excluding this. We just wanted to show those that were most reported, but in the report on our website and here, you know, we have those other autoimmune diseases. As I mentioned, the prevalence of those is rather small, but we do have those captured, and we'll be looking at those in the scope of multi-site study.
Okay. Any questions in the room? Andrew?
Marion, can you hear me?
Yes, I can hear you.
So you talked about how the P's levels have dropped over time, but are still elevated when compared to the national average. Can you speak to have the PFAS levels dropped at a rate consistent with what you would expect with the half-lives that we know about these chemicals? The different PFAS have different half-lives. So is that consistent with what you're seeing? Are we tracking on with the half-lives, or are they slower or faster? Or is that something that the study is looking at?
Yes, so yes, we were able to, since thank you for the question, since you asked that, we were able to have a little bit closer look. Mandy, if you can go a few slides before this. I think I can show. Yes, so here's NHANES. So here you can see the NHANES change or decrease in the levels between 2017-18 and 2013-14, which is about the same, about 4 years as between 2016 and let's say 2020, which is the change for P's. So you can see the percentages here, you know, ranging for 13 to 30. They're a little higher in children. They do get lower a little bit more. So what we're seeing at P's, since the levels are a little higher, if you go to the previous slides, at P's, you know, those decreases are higher, and we would expect that in a sense that you know, when you start at a higher level, you would see larger decreases, you know, over time here. And while we do have the data, you know, for these participants, we do not necessarily have exact data on dates on when the samples were collected. So we're not able to really get to, you know, calculating exact half times, but we can definitely look at the change, you know, and as you can see on the average changes here, you know, the decrease in P's is higher on average than it would be at NHANES.
Okay, thank you. You said, or on the slide, it said we can expect the second part of the P study results pertaining to health effects in 2024, 2025. Is there any, can we be any more specific than that? That seems like a big range, so I'm just curious if there's.
No, the range was referring more to our work on the health outcomes. You know, we do not expect to cover, you know, all possible outcomes, you know, all at the same time. So we'll be working, you know, continuously on our end at ATSDR and with our partners, you know, at multi-site. So I would believe that we would like to, you know, show you what we have in 2024, you know, instead of waiting to 2025. We are working on the outcomes, screening, going through the reported outcomes, and also started work on LabCorp results and other clinical and research biomarkers tests. So we will be, as we'll be going through that, we'll be you know, informing you through our, you know, regular CAB meetings, you know, about the progress of our analysis. And once we go through all of that stuff, then it will give us a little better picture when we are and what we can present to you, you know, on P's results per se. And then once we get to that point, we'll be able to, you know, specify the, you know, kind of narrow down like where we can, you know, present those results. As you know, we're also working very hard on streamlining, our procedures with Dr. Bernstein on clearing presentations and the results, so that also, kind of affects our estimates on when we can present those results.
Thank you. In terms of the multi-site study that PEAS is going to contribute to and be part of a larger study, how will you report those results? And when you share that information, is it just going to be as one big study, or will there also be presentations on each individual site?
So as I mentioned, the results on multi-site study will be similar. People will be presenting, at their individual sites, but the real advantage and focus of the multi-site study is to have those aggregated numbers. So we have started work, on the methods, or kind of similar to here, kind of presenting, demographics of the cohort, PFAS concentration for the cohorts, and then, outcomes. So all of that will be by site, right? All the descriptive data will be presented as, by site, so that people can see like what the distribution of the PFAS and health outcome is. So it won't be at least on a descriptive level, we'll have to show all the results, and then the aggregated results are necessary, like I mentioned, for whether the autoimmune disease or diabetes. It only can go that far with the 60 or 70 health outcomes or the sample size. When you get to 300 or 400, it's much more impact for that kind of product.
Okay, so we can expect that each site is going to have their own individual meetings similar to what we're having here. And then ATSDR will host a meeting that will talk about all the results together.
So yes, I think that all the sites would like to inform their community, that they're completed the results, and how many participants, something similar to what we are doing. And then, we had during our all multi-site OPI meeting at the end of September in Colorado, we have outlined a kind of preliminary plan, on to how to look and prioritize certain outcomes that, have been reported more to be associated with PFAS. But I think, the range is really broad, and we have a lot of collaborative partners. So I think we'll be able to get to number of those outcomes. But the idea really is to start work on number of manuscripts, as being part of the National Academy of Sciences and Medicine, reviewing, the PFAS results. But you want to really kind of, instead of doing the reports, you want to publish the peer-reviewed manuscripts in scientific journals and present the results at scientific conferences, so that not only like public but scientific audiences, can kind of judge and review and critique, what we're putting out. So really, we're envisioning a series of papers, 10 to 20 papers that we would be working, with our partners on the multi-site study.
And a follow-up to that, would those papers need to be published before you would report results?
So that remains to be resolved. My personal take on that is, which has not been popular recently because of the kind of spread the way that CDC operates. We want to have everything cleared before the things are presented to communities. When you go back maybe 10-20 years, we would present preliminary results at the meetings, but the scientific meetings or community meetings. so that people could see, you know, where we are and what our preliminary results are. These days, because of the scrutiny of the press and, you know, internet and social media, when you release anything, you know, people can document that and see the results. So what happens with preliminary results is that they're preliminary, and there may be changes later on when those same results undergo, you know, peer review process, whether at the agency or later at scientific journals, right? So you present slightly different results, not necessarily that those results change. Like, for example, our piece report didn't change much between November 2022 and January 2024, right? Nevertheless, what I was trying to say, that I think it's imperative that we find ways of how to get the results to communities as sooner or as soon as we are confident that the results that we have and undergo, you know, the review process in a reasonable amount of time.
I have two more questions. One is, I know the answer to this, but I'm just asking on behalf of the community. Are there ways to lower PFAS in your blood faster? If anyone is curious about that, are there approved ways to do that?
So clinically speaking, we do not have a approved method. Like, you know, there are some methods for decreasing, you know, levels of heavy and trace metal chelations that are clinically available. I'm not aware that there's any clinically approved method to reduce the PFAS in such way. So our kind of what you see in the physician's recommendation material as well is the prevention of exposure or avoidance of exposure of the potential sources to PFAS that may be. And as you can see from the numbers for PEACE, you know, the knowledge in the community that the wells or that the water was contaminating, and then a kind of adherence to that, you know, using a lot of bottled water, avoiding the source of contaminated water. You can see like how effective that was, right? In those 4 years, the levels at PEACE halved for, you know, PFOS, PFOA, PFH excess, right? So I think that really that kind of prevention, you know, was really effective and worked. Nevertheless, there's number of sources, but through food, there's sources that they're, you know, discussing in North Carolina that manufacturing facility may be, you know, releasing stuff into air that then later goes to, you know, not only water but soil, food, and other sources. So I think knowing and being able to inform communities of potential sources of PFAS is an effective tool, and I think it worked quite well at PEACE.
Marion, I just want to be mindful that I think Andrea has at least one more question. I think we have multiple questions online.
Yep.
So let's make sure we, and in the interest of getting through all the stuff we need to get through, let's try and keep our responses as concise as possible.
My last question is probably more directed towards Dr. Bernstein and Dr. Ray, and that one thing the PEACE community has advocated for many years is a longitudinal aspect to this study. You know, we're very appreciative of the study and the work that's been done, but it's a cross-sectional study. It's a one snapshot in time. And we really want to know how this exposure is going to affect our health over time. And so I'm wondering if there's any answers regarding, or any thought or planning or commitments that can be made to a longitudinal aspect for our community.
Sure.
And I'll sit down. Thank you.
Yep. Thank you, Andrea. So to me, I think that's the conversation. I want to hear more about what the objectives would be. So if the objective is to understand health outcomes, I think it really behooves us to see what the multi-site study shows, because that will help us understand what health outcomes may be in play, recognizing that to see signals in rare diseases, you need a massive number of people in a longitudinal study. And so understanding what the objectives are will be really helpful to thinking about that. And then once those are defined, then you can say, okay, how many people might you need to do that, and how much money would it cost? And then we have a conversation about where that funding would come from. So those are the next steps in my mind on that.
Can I just make one follow-up point to that, in that, you know, we're coming up on 10 years since our contamination was discovered.
Yeah.
It's taken a long time to get through these processes, and my worry is the more we kick the can down the road, the less engagement we get with people, and, you know, we have a study, we have people engaged, and I just worry that the longer we wait, multi-site study is gonna take a while to
Yeah.
process that information. We could lose more people over time.
Yeah.
And so, I'm cognizant of that, and that's something that worries me the longer that we wait, but
Yeah.
thank you very much.
Yeah, so the challenge with doing it now is I wouldn't know how to do a study because what diseases would we look for and how much time would we need to actually, we're talking decades of work. So in the span of decades, having a year or two to make sure we get things right. I get the enthusiasm piece, but if we start too soon and don't know exactly what we're going for, then it's time we spend a lot of time and money and we will not find what we actually want to learn. And then there are goals to these kind of studies, like what are the factors that might prevent risk? So your PFAS exposure is one thing, but how about your diet influence the risk? Is I think a valid question that might be known. But if we don't think about that in advance, we won't have the study set up to do those things. So if the question is how can we prevent disease rather than what diseases will we get? It's a very different study, right? So we can get a lot of information about things that, like with the multi-site study and the other studies, we can see what diseases may be at risk. And we can do longitudinal studies to dig into that more. But I do wonder if people in the community really want to know, like, okay, we know there are diseases at risk and we can understand other diseases, but maybe we can also look at like how we can prevent ourselves from getting sick. So if that's an interest, then we need to think differently about how the study would be designed, the kinds of questions we would ask and things we would look at. So as we spoke about, I'm very eager to hear about what people want from that study. So that's to everyone in the room. If this is of interest, like I do want to know what people know. Like, do we want to know about diseases? Do we want to know about things that can prevent disease? I mean, some people may want to know, like people who use water filters, like how does that affect their levels or not? I mean, that's been done in other studies. So there are many things that can be done. And again, because of the expense and time invested, it's really important to make sure that people are clear about what you want before jumping in to have it come out.
So we have some online questions.
Yeah.
So Brandy, if you can read the online questions, and I want to point out, we have 71 people online, so there's quite a few people online. So thank you for being here. Brandy, can you read questions?
Yes, absolutely. So the first question is, for the analysis of those who had 2 blood draws over a 4-year period, what baselines benchmarks do you have, if any, to compare to?
So that would be the NHANES National Health Survey, that is done by CDC. So we have different years of NHANES that are available since 1999, 2000. So we're comparing to the recent ones from 2017, 18, or the one in 2013, 14.
Okay. Next, Brandy.
Next question is, what does the healthcare provider reported column reported mean? Is it connected directly to those participants to verify the self-reporting? And then also as a follow-up to that, what is NHANES?
So as I mentioned, NHANES is biannual survey conducted in US, which is representative sample of adult population and asks a lot of questions about behaviors, social, medical, and other occupational history. And it does also measures up to, I think, 250 or so chemicals, and PFAS are one of those. So it's a very useful tool to kind of see what the average kind of general US population background is in general population. The first part of the question, what was the first part? Can you read that part?
Certainly, yeah, it is, what does healthcare provider reported
Right,
column
healthcare
mean?
provider. So we had two, as for a number of diseases, a self-report is not necessarily the best reported outcomes. There are a number of diseases that participants do not necessarily recall exactly. So the second part of that was that we were looking to also get the responses from the providers that participants identified, and they review the medical records and provided, those numbers that we report there. The percent there is, like how many people, what kind of concurrence we were going to get there. In some of those slides, if we can get back to those, we see very high concurrence on diabetes or high cholesterol, which is over 80%. So those are, excellent numbers. And we'd like to, thank the app staff and other staff on the study that, spend a lot of time trying to get through those verifications and working with the providers.
Next question, Brandy?
Since PFH-XS is the highest on your scale, and in the current world of vaccines, have you any recommendations to your point that PFH-XS lowers antibody response to vaccines?
Well, so we have not yet looked at that at the PEACE study or multi-site study. It will be, part of our paper that we'll be looking at, with our cooperative partners.
Next, Brandy?
Is there a plan to redo the study with adults? We saw that there's a new study starting up for retesting kids of certain ages.
So this is something that Dr. Bernstein has mentioned before. I think he covered it fairly extensively.
Thank you. The next question is, will raw data sets be made available to the public? For example, I would like to see sample distributions in addition to seeing aggregate geometric mean values. It's difficult to the layperson to see how the samples are distributed.
So I would like to direct you, as I mentioned earlier, the PEACE report was released, and there are figures for individual PFAS congeners that include the distributions in males and females across different age categories. There's figure 2, A, B, C, D, and you can look at the distributions there. We can also show a couple of slides at the end in my supplemental slides if you want to go there for a little bit, or are we out of time?
That would be good.
That'd be good.
So next
Tell me
one.
what you're looking for, Marian.
Yeah,
So,
the one before that one.
thank you.
So this one is in the report. I don't know how big it is on your screen, but when you look at the report at ATSDR, you can see it's pretty large. It takes like almost half a full page. So those are fairly well readable, and you can compare how the distribution changes between PEACE and NHANES. There's mean, medians, and the box is kind of 25th and 75th percentile. And then you see the full distribution there for males, females, and different age categories for PFOA, PFOS, PFNA, and PFH-XS.
Is that it?
That is it for the online questions.
All right. Any more questions in the room? Thank you.
Could you please clarify the multi-point study? Is that geographic multi-point, extending the radius from P's? Because I didn't know if that was a medical usage.
Good question.
It's the multi-site study, and this is a national health study that ATSDR is in a cooperative agreement with 7 other sites around the country, that each site has their own PI. There's a site here in New England that Laurel is leading the work, and there are 6 others. And so at the end of the day, we're going to have data from 8 total sites counting P's. And that data is not only, as Andrea said, will we be reporting out on site-specific data like we're doing here today, and we'll do in future meetings, but also we're going to aggregate that data and do one larger study, which will give us more power to look at health effects and exposure in these cohorts.
So it's not contiguous to P's sites, it's other places in the country, and you're looking at the correlation between their exposure factors and our exposure factors?
No correlation between exposure factors and disease.
Yeah, so we use the same protocol, in Pennsylvania, New York, New Jersey, California, Colorado, and Michigan. It has the same protocol and same measurements for clinical and biomarkers and PFAS as we did at PEACE. So
Okay. Okay, thank you.
Okay.
Yeah.
Great. Yes, sir.
I want to call audible, Chris, because
Okay, go ahead.
I realize it's 7 and I want to make sure Laurel Scheider, the Silent Spring team came here because they want to present a little bit about a study that they're conducting in the community. And Brandy, if you could go to their slide next, I want to give them the opportunity just to speak about the study for a minute. Thanks.
Thank you.
Okay, great, thanks. So my name is Laurel Shader. I'm a senior scientist at Silent Spring Institute. We're an independent nonprofit research organization based near Boston, and our mission is to study links between everyday chemical exposures and health, with a particular focus on women's health and breast cancer prevention. I've been involved with PEAS since 2015, when Andrea and other activists from Testing for PEAS reached out to us. I've been involved with the PEAS CAP as a technical advisor and a part of the Portsmouth Safe Water Advisory Group. So I'm here tonight to tell you a bit about a different study that's currently underway at PEAS. And for those of you who took part in the PEAS study or maybe didn't take part in the PEAS study and have children, you may want to sign your children up for this study. So this study is called PFAS REACH, which stands for Research, Education, and Action for Community Health. Our team at Silent Spring is partnering with Northeastern University and Michigan State, as well as with Andrea Amico from Testing for PEAS. And our goal, if you can go to the next slide, is to better understand links between early life exposures to PFAS and immune system effects. So whether antibody levels in response to routine vaccinations are affected, as well as to apply novel, what are called metabolomic methods to better understand the mechanisms by which PFAS may affect immune system function. So that's our broad goal. For our eligibility criteria, we're looking at responses specifically to the DTaP or Tdap vaccinations, so diphtheria and tetanus and pertussis antibodies. So we're timing our eligibility around those vaccinations. So we're looking for children ages 4 to 8 or 11 to 15 who may have been exposed to PFAS from the drinking water at PEAS back before 2014 when the levels were still high. And so children may have been directly exposed if they were at daycare at PEAS during that time, or indirectly if their mothers worked at PEAS before then. We do know PFAS can be passed along during pregnancy and through breastfeeding. So participation in the study involves just a couple of steps, and it's somewhat similar to taking part in the PEAS study was like. So if you enroll in the study, we would ask your child to provide a blood and urine sample. We're working with a mobile phlebotomy company, so we can actually come to your house to do the blood sample. We also have a questionnaire to complete, and then a series of text message surveys to ask and track infectious disease symptoms over time. For people who take part in the study, the bottom of my slide's cut off, you can receive up to $125 in gift cards. You'll also receive the results of the PFAS blood testing. So if your child took part in the PEAS study and you're curious to see how their levels may be changed over time, then you'll be able to compare your results. You'd also receive the results of the antibody testing as well. So we're aiming to complete our sample collection this spring. So if you're interested, please do reach out to our team. On the slide, you can see our phone number where you can call or text. We have an email address, and you can't see the QR code because the bottom of the Zoom is covering it. But we also have a table with materials outside. So please do take one. And even if you're not eligible, if you know other people who might be, please do help us get the word out. So thanks very much to ATSDR for coming here and sharing this update tonight and for giving us these few minutes to share an update about our study.
Yep, a moment to take questions.
Sure.
There are. Randy, do you have any questions online? Randy?
No questions related to this online.
Any questions in the room?
I'm really concerned about the level of PFAS I acquired while living on PEAS during my formative years, ages 6. I have 2 children, and I'm really concerned about what I passed on to them. And I'm really concerned about particularly autism and developmental problems and mental problems. Are there any studies going on that address these? And presumably living on PEAS where I lived, bathed, went to school, swam in the pond, played in the streams. I feel like I might have had more exposure than people working on these, I don't know. But like, I'd really like some answers about what went through me to my kids, and is there any work that be done on that, because we don't know.
Right.
And my kids are 15.
No, those are important questions, and I understand the concern about your own health and your children's health. I do think what we learned from our study and what will come out of the PEACE study and the multi-site study will help address those questions so we can understand for children who are exposed to elevated PFAS early in life, are they at greater risk of certain health outcomes? Testing their blood for PFAS could give you some indication about their PFAS exposures, but it is very difficult at at an individual level to be able to link chemical exposure to a health outcome, but
The study, the PEACE study seemed to measure children who were already born and their exposure and like ADD and autism. And I imagine that there is greater insult to the baby in utero when they have PFAS. So I'm concerned about that. And like with the PEACE study, how does the incidence of ADD and autism compare to the general population? Like, is it higher than the general population?
yeah. I do think that from the multi-site study that which will also include these results that will be able to provide some answers. The other communities that are part of the multi-site study are located in communities where there was exposures in the home, so residential exposures. So there might be more similar kinds of exposure pathways to what you experienced. So hopefully that study will be able to provide some answers to your questions.
Well, I'm sorry, remind me of your name, please. Antonia. So what I didn't mention is I'm also a pediatrician, right? And I have heard your story too many times from my particular care. It pains me every time I listen to a mother talk about their, child having been exposed in utero to a chemical for which 20 years later, someone's saying this could cause cancer. I mean, as a parent, as a pediatrician, this is a horrible, horrible thing to do to anything big. And on top of that, to have the uncertainty of we can't be sure, to your point, whether this is worse than being exposed afterward. We do often expect that when a fetus is exposed to something, it may be worse. And then what do we do about it? And to the question Andrea was like, we don't have medical treatments to lower levels that we're confident are safe and effective. This is a horrible, horrible situation. And I think, you hear in so many voices, people in this room, people online, that this is not acceptable. And I hear that. And I committed, myself to this work because I wanted to try and make a difference, recognizing that it's hard. I do think, the study that is being proposed here is not going to necessarily immediately benefit you and your children, but it's part of a bottle. None of this happens fast enough for anyone's desire, especially mine. And so, what I'll say as a pediatrician is when I'm faced with situations like this with families, I say, here's something that happened that is potentially horrible. I don't know that for sure, but there's plenty of reason to be concerned. And I can't control, what can we do? We can try and reduce exposure, but the exposure has been reduced at PEACE to a large extent. There are sources we can work on, but then the question is, what can we control? What can we do? And my answer comes back to, okay, there are things we know we can do to promote the health of our children that really matter, that, may not be the tip of the spear with PFAS, but I can't do anything about that, at least in many circumstances, besides war. And so that's what I try and focus on. Okay, so cholesterol is a risk. We know the other things that affect cholesterol. Let's think about that. How can we make sure we're giving that child the best chance of having, healthy cholesterol based upon their diet, their exercise, stress, whatever, sleep. Those are not necessarily easy things either. So
I guess my question is, I would love it if we could participate in the study so that we could add to the answers.
Yeah. Participate in the multi-site study.
Whatever study is appropriate that we would be able to.
Yeah. So one of the things that I think is critical, and I addressed the question on longitudinal study, you know, and there's so many ways to try and get at that. And so I'm thinking, okay, who are the partners I know that I can call who have birth cohorts? Some of them are in New England where they're studying, you know, they enroll people who are pregnant. And actually a lot of those folks, I actually was thinking, work with our lab. Our lab does the PFAS measurements, but they have the birth cohort. And now having heard your question, like they publish all the time. I don't know if they've tried to address some of the questions they have, but to Andrea's point, like this would be a longitudinal study. So you can look at a point in time and say, okay, they're exposed to this, do they have autism at age 3? But really, if that's a question about risk, then you'd want to follow across time, because if they're not diagnosed with autism at 3 and you miss them, you know. But I think that's one way we can be a resource, is not necessarily doing research ourselves, but being aware of other research that's ongoing. And I'm happy to follow up with you on that question. I'm not saying I know of a great study to participate in. Many of those studies would have enrolled already when you were pregnant, but the point being, those studies might give information that would be valuable to you, even though you weren't in the study. If that makes sense. Yeah, but this is exactly the kind of feedback I want to hear. Is, you know, we want to understand better in utero exposure. We want to understand that versus getting exposed to a child. We want to understand breastfeeding risk. So I think your study is going to look at that. These are really important questions, and I think the challenge is the answers always take longer and are less clear than we want. Be wary of people who give you absolute certainty on PFAS. I mean, don't get me wrong. I'm very convinced that there are health problems, but that doesn't necessarily mean that because we know it affects the liver and potentially the thyroid and these things, that any individual who's exposed is going to have that problem, right? That's the topic. Okay.
Right.
I'm sorry, Laurel, was there anything else?
No, it's it. Thank
Okay.
you.
Just being mindful, yeah, sorry, go ahead.
Just another question. There's childcare on the site now, and the water's being treated. How is it being treated? How do you get the PFAS out? You can't get it out of your body. How do you get it out of the water?
I don't know specifically about some people in this room actually.
We've got people out of water. Yeah.
May know exactly how it's being treated.
I got this.
Activated carbon.
PFAS is non-detect all the regulated.
Yeah.
Hi, I'm so sorry to interrupt. Could we have him come a little closer to the microphone for all of the folks online? Thank you.
Sorry, the response, it was, do you say activated charcoal?
No, resin and granulated GAC carbon.
Resin and GAC carbon.
Granulated activated carbon. Correct.
Was that clear?
That was clear. And there's a follow-up question online that someone would like answer to. It is, to all those who participated in aggregating the study and knowing what information has been developed so far, would you personally drink the water at either Pease or the greater study area, Newington, Greenland, Portsmouth? More importantly, would you allow your children to drink the water in these communities?
So I think I would allow some of our folks who are intimately involved.
Fill that up all the way here, yes.
So we've got people living in the community responsible for monitoring water who are drinking it.
And I'm the director of water for the city of Portsmouth.
Director of water for the city of Portsmouth. I would take that as a better endorsement than mine. Just out of curiosity, how many people in the community here are concerned about drinking the water right now? Yeah. What would it take to have you feel more comfortable? Yeah.
Free testing.
Free testing of your home tap.
I know, because there was a program, but it wasn't, I don't think it was measuring PFAS.
And so your concern is that PFAS is, so I presume the water coming into homes is being tested in the community. And so your concern is PFAS is getting in between
Wells.
the private wells.
Yep.
Yes, got it, yeah. Yeah.
I was gonna say, sorry, I'm Tara.
Tara, come on. Here.
With the ATSDR one, and my contact information will be up here, and you know, we work with our New Hampshire state partners too, and they have some really good resources for private well owners that I can direct you to. And that can answer some questions about how you can get well testing in New Hampshire. And if you have your well tested, how to interpret those results, because it is really important, right? Like, I think that question was directed towards the public drinking water system, if I'm understanding, Randy, the question. And there is in the surrounding community and in a lot of New Hampshire, there's private drinking water wells too, right? So Brian represents the public system here, but there are lots of other private wells. And even in Newington, there's private wells, like close by, there's private wells. So we can get you some of that information if that's helpful.
Okay, thank you.
Sure.
Excuse me, Peter Saban again with the Department of Environmental Services, I think said that if you have a private well.
So Randy, I think in the interest of time, I'm not going to use slides. I'll just walk folks through.
The Air Force has a very extensive.
And
private well
I don't like
monitoring
PowerPoints
program.
anyway. So, many of you will know that a little while ago, we released updated information for providers related to how to deal with PFAS exposures. And the impetus really for this, I'm relatively new to CDC, but it was very clear to me that the impetus really did come from communities around the country saying we're concerned about PFAS. One of the places we go is to medical providers, and we're not being listened to. And so a primary objective of this information was to not only present to providers what we understand about health effects, how to think about testing and management, how to reduce exposures, but really to try and get a mindset change, which goes from a mindset of, well, there's nothing we can really do here, to actually there are things we can do. Let's think about them together and try and make the right choice for the individuals who come in. So, in big brushstrokes, a big part of what we do is focus on exposure reduction to the extent we can. So again, for many people in this community, that's not the issue as much as, what do you do once you've been exposed? But in many communities, as you know, they're discovering PFAS contamination on a regular basis. And that may be from water, it may be from farms, it may be from other, industrial facilities. And I think there's a really important emphasis to make sure providers understand that there are routes of exposure that are known, and to the extent that they can be avoided, we should avoid them. There's also, of course, testing, which is increasingly available. New Hampshire is a state where my hope is people are feeling it is more available than not, given all the work that's been done to make it available. And we wanted to be clear, that when an individual comes into a medical office and says, hey, I want to be tested, that both that individual and the provider understand what testing can do and what it can't. What it can do is certainly detect PFAS in the blood, particularly based on what's being tested. And one of the things we're working on now is reality that for people across the country, there's not standardization. So if you got a test in New Hampshire and you got a test in a different state, you might get tested for different PFAS with different methods. And the PFAS that you're tested for might not be the PFAS you've been exposed to. This is particularly true in certain communities, industrial sites where the PFAS are very different than the national ones. But nonetheless, if you look across the United States, there are really 4 that most people are exposed to. That includes the PFAS that was found mostly in folks in peas. And there may be members of the community that are worried about exposure, as many of are who've never been tested, and they might want to know that they don't have it. So that could be reassuring, right? So you live in a community, there's been a lot of PFAS in the community, you have a test of the PFAS known to be in that community, and it's not there. I think that would be a substantial benefit. There are individuals who want to know what their level was at time 1, and they want to know what it is at time 2. Some of the questions around, is my level falling? Given, either an active intervention, like you have a private well, there was PFAS in it, you put in a filter, you want to make sure you can test the water, and you can also test yourself. And there are many other reasons. We ask clinicians and individuals to really consider what is the potential of a test to reduce exposure, and what is its potential to inform potential actions to improve health. So a good example that also might be cholesterol, right? So I was just talking to someone recently who knew someone who's a firefighter, and firefighters are among the most dedicated, hardworking individuals in our communities and least likely to take care of themselves. And the reason that this firefighter went into their primary care office was because of PFAS. They had never been screened for cholesterol. And so, you know, what our information says, okay, there are screening guidelines for cholesterol, we should use those. And those are not just based upon, they're based upon, you know, an individual's history. They're based upon a series of questions that providers ought to be asking about when we should screen. But even in those recommendations, often young adults aren't screened, right? So 20 to 40-year-olds would not routinely be screened. But boy, if a provider has someone come into their office saying, I've been exposed to PFAS, and that person falls in an age group where they weren't tested as a child, even though that's recommended, and they're not necessarily old enough for routine screening as an adult, that would be an opportunity. I'd say that individual may say, I don't really want to know my PFAS level, but I do want my cholesterol screened. And that would be to our message providers. That's exactly the point. Like if you get and a PFAS level could also be helpful to that individual. But the point is cholesterol is something we can definitely do something about. And when we say one of the things we point to in testing is how does the test relate to existing guidance, right? So we have a lot of guidance around cholesterol. And if someone's going to be screened anyway, then do you need a PFAS level to screen them? Again, not necessarily unless the person has one of those other reasons, like I want to know if I was exposed, I want a baseline, these sorts of things. But you get my point. So it can be a motivation, we're hoping it can be a motivation for someone in the case of cholesterol to be screened either for the cholesterol independent of a PFAS exposure. And then there are, of course, a whole bunch of questions around if you choose to get a PFAS level for whatever reason, and you can get it, which is a whole nother challenge. What do you do with a particular level? And the National Academy of Sciences, who we co-commissioned to look at that question, provided a series of thresholds that would say that over a certain number, they would recommend certain tests, like a cholesterol level. And again, our messaging in this information is, if you're going to use those pieces of guidance, which again, many people are, and the NACEM report was extremely well done. I know many of the authors. It's important to realize that the PFAS levels that they used for the thresholds were aggregates, right? So they're not based on one PFAS, they're based on your total PFAS. So you can think if you go to a testing center that isn't testing for the same PFAS that were in the study that was used to make that, maybe your level isn't the same thing as what's being given in those levels. It's also true that the levels that were used to make those assessments were not done in the United States. Now, that's not because they chose to do that, that's because we didn't have data in the United States. And so again, whether those levels are really reflective of what we would see in the United States is not known. But I'm hopeful that, for example, the multi-site study will give us more information to do that. But again, this is our point. It's to make sure people are informed if they choose to use these pieces of data, to make sure they know what they're getting, right? We don't want people having false reassurance, and we don't want people having false concern, given what we know. So again, with the issue of levels, we're very clear. Here are the things that this is where it comes from. It's based on an aggregate level. You need to understand what PFAS you've been tested for. And oh, by the way, a PFAS level of 2 to 20, which is in the range. So they have 3 gradations in the NACEM report. They have less than 2, 2 to 20, and over 20. I'm thinking if a person is at very high risk for high cholesterol, they haven't been screened for cholesterol, and they have a level of 10, and they walk into my office, I'm probably going to screen them for cholesterol, right? Now, the NACEM report doesn't say don't screen them for cholesterol, but again, we just want people recognizing that this is, this is based on one set of data from European country with levels that are based upon an aggregate of PFAS, which may not be representative of the aggregate that individuals are being tested for in the United States, which is kind of complicated to get your head around if you really dig into it. So we're really trying to focus clinicians on disease risk. So like a lot of people are concerned about thyroid, for instance, right? So we should be, providers should be asking in someone who's been exposed whether their PFAS level has been tested or not. Another thing in this community is important. levels have gone down. Thyroid disease doesn't necessarily appear the day you get exposed. So if you get a PFAS level that's 5, do we not screen for thyroid disease? Right? We need to think, and we need to ask the right questions. So we prompt providers to really think about, that's why the disease associations and this information are there to say, okay, we know that PFAS is associated with cholesterol, not powerful cholesterol, but it's one that many people know. And, you know, is this person at risk given their family history? Does this person have risk for heart disease? Has this person been screened previously? Independent of their PFAS level, knowing that they've been exposed, and that's the first thing we ask people to think about. What, you know, it's their first thing for people to think about when someone's considering testing is, what is your exposure history? Not what your PFAS level is, what is your exposure history? That may help people make decisions. And again, we also appreciate that people have very different perspectives on this. Some people really are just interested in understanding the risk of disease. Some people are really interested in understanding their PFAS level. And again, our goal here is really to provide the information that's going to enable individuals to make the decision that's right for them. The last thing I'll say 2 other things. As I mentioned, we're very interested in working on the standardization of testing. We see that as critical so that people don't have to think about it. Being tested for right PFAS, the provider have to know. There are some communities that have been affected by PFAS where blood testing is not helpful at all. That's a real challenge because the PFAS don't stay in the body long enough to be detected in blood. Whole other challenge. But for the most common PFAS, we want to make sure that people have access to standardized testing, and so that we can compare values over time in reliable ways, that people know what they're getting. We are very committed to working with providers. We need to get feedback from them. I'm working with medical organizations to get people, you know, see how they're using this, to understand how useful it is, how it can be better. This is a long-term process, folks. I would like to believe that every provider in this country is well-versed in environmental health and that they listen to people who come in with concerns about exposures. I'm not sure that my wish has come true yet, but this is a part of a broader issue that isn't just related to PFAS in many cases. And the last thing is, as I mentioned, is we're very keen to learn more from communities like this one about whether it's the studies that need to happen. You know, again, that's not just us, like a lot of the research, you know, Dr. Shader's work is supported by NIEHS. We work closely with them. They provide funding across the country. You know, there are many mechanisms to do this, but we can hopefully help navigate paths to research. Very interested in community input on our own work, whether that's, you know, we talked about the multi-site study. You know, I'm very happy that there was support raised in no small part to people in communities like this around the country to get support for community-led. So in these 8 sites, there's the main study we talked about, which will be very similar to this study. But each site, you know, the studies are going to happen here in New England and around the country are investigator-led, meaning they're designed in those sites, and those results will be separated from the government. And I think that's going to enable flexibility that will be really good to. So when is it Antonia? I'm sorry.
Yes.
And so like when parents like Antonia come into those community meetings, they can adapt the questions they're asking to what they're hearing in those communities. Because again, each community has different issues. So I'll stop there. And I hope that was audible to people online, and happy to take questions.
Hi, Ari.
Yeah.
We have a question online. It is, can ATSDR comment on why their new clinician guidance doesn't recommend PFAS blood testing or medical screening?
And do you have a name on that question, Randy? Oh, they all come across as Brandy. Okay. Well, thank you for that question. I want to be clear that I don't know that that's what I read in our guidance. We don't say anywhere to not test or to not use the NASEM levels. If you read the document closely, you'll see what we say is, you know, if there's an interest in testing, here are the things we want providers and individuals to think about as they pursue it, right? I think that's a very different statement than don't test people. And I also think we're very clear in the section on the thresholds. We don't say don't use thresholds. We say if you're going to use these thresholds, here are things that would be good to understand, like
this is where they came from. Here's what they actually measure. You may not be tested for the same things that are in these levels. And that would mean both that your level might be low and you ought to be, more concerned, or your level might be high based upon a population average that's not in the United States. And again, we didn't want to presume, especially given the variability of exposures in communities with their hotspots, that there was, absolute clarity to say everyone ought to use these lock, stock, and barrel, no questions asked, or everyone should be tested independent of the things that I think many reasonable people want to know is like, okay, if I get tested, what can I do with it? I think there are medical management things we talked about. I think there is knowledge that can be very powerful. There are lots of good reasons, but I think it's really important to think those through as you approach those things. And I think a big thing with testing again is we do see greater coverage, which is great. And we do see more concentration of lab availability. But an important thing, which may be a little subtle piece in the information, is that we're very clear that providers need to use CLIA certified labs, and CLIA certification comes through FDA. And that's really a quality standardization piece, right? So some people have been getting PFAS testing from non-CLIA labs, and you really have to worry about the quality of those tests, which wouldn't be immediately available unless you knew that. So I hope that answers that question. And Brandy, let me just take a question in the room if that's okay.
Absolutely.
Okay, go ahead.
When you talk about standardized testing,
Yeah.
are you talking about regardless of exposure? So that across the country, children could get tested? And even though it's a very complex issue, what do you do with that? At least you know if you need to reduce exposures.
Yeah.
So would it be sort of like blood lead testing in children eventually?
So, the issues, so that's one of the issues. So you raise a bunch of issues. So at a first pass, there's a couple about standardization. One is the assay, right? So there are different ways to test for PFAS, and every lab, even using like the same equipment, there'll be different protocols. And so I think one of the key pieces is that, like, I'm having conversations with some of the major national lab testing companies to really dig into their plans and how they're planning on testing, and will they have consistent assays across their sites, so that if you do get tested and retested, you can, I mean, a good example, I think as a clinician, there are many examples over time where people, like thyroid testing, for years was not standardized. It isn't standardized now, and people get their thyroid tested in two different places, get two different results, and they think they'd have thyroid disease on one day and none on the next, just because of how the testing was done. It used to be that way with other lab tests too. And that's sort of where we're at with PFAS testing, but I'm seeing that change quickly. So I think that's one piece of standardization is how quickly can we get to a point where people can go to labs and be pretty reassured that, yep, this is reliable. And I think, again, in one community that works through a given lab, that should be the case now. Now, the other issue is, okay, what PFAS do we test for? Well, there are 4 that are common in many communities. One of them is from AFFF, the firefighting foam, the PFH-XS. That's what's here in Peas. It's in many other communities. That is among the 4. And there's, PFOS, PFOA, PFNA. So if you had to choose, those would be the 4. And so I'm hoping that, we could say to the question that was earlier, like, not only could we say you should be tested for these 4, if nothing else, and I'd like us to get to the point where saying, if you test this year, you should, and your level is X, you should retest at a certain time to see if if you have a high level and you're reducing exposure, your level should get to Y, right? And I think that second time point, and I think, Andrew, you raised this question, is okay, in Peas, we started learning information about, in this community, we had a certain level from PFH-XS, how the level fell. And the multi-site study, my hope, is going to give us a little more information in that regard. And so we'll get to this point of saying, here are the 4, here's when you can test, and if your level is X and you retest, here's the decline in level. So that would be a standardization as well. It's not just what you test for, but how often. Now, in children, it's another good point. I think the multi-site study may have the biggest cohort of children ever enrolled in a PFAS. I could be wrong about that, but it's going to be among the largest for sure. And so, you saw some of the dice from Peas. There are definitely levels that are high in children. Does the same level in a child mean the same thing as an adult, right? Do we need different thresholds in children? So these are questions. I think the issue for children is our data is lagging. So, but yes, I think that would absolutely be, as a pediatrician and dad, like, I'd want to know, like, Kids are not little adults. I don't think we should just take the adult level and say, and this is another good example with the thresholds. Is it really okay to say that over 20 is the right time to screen for all people, including children? I'm not so sure. It's another consideration. So those are the kinds of things I want to think about with standardization, but it really starts with making sure we're testing for the same thing as much as we can in the same way. And then all those other things come in.
Well, I think one of the community concerns here is that we're very fortunate to have the studies done here. And we're a pretty fortunate area to live in too. It's really important that whatever's learned from these studies, even if the studies aren't completed, that sort of gets spread out to all children in this country and not just the ones that are fortunate enough to have representation here, you know?
Yeah.
And because this is a child issue, we don't know but it really is very important, and the original CAP members and RAB members are really concerned about making sure that there's environmental justice, or there's social justice that comes along with this study as well.
Yeah. And I'm sorry, remind me of your name.
Kim.
Kim, thank you, Kim. So I couldn't agree more. I mean, I know you will all hold us accountable to making sure we do that, and I will commit to you here that that is very much of my interest as well. I find it. I was.
I do a follow-up on the water system.
Yes, I'm sorry, your name.
I wasn't quite prepared the first time around. Brian Getz with City of Portland Water. So since it was asked, let me clarify. There's been a lot of discussion of PFAS testing, you know, in the blood. The water system, we've been testing for 10 years now. So, and those are certified tests. The water testing for PFAS is different. It's different protocols than blood. But all that information we test. The Portsmouth water is tested every quarter, and the Pease water is tested monthly. All the filtering and everything done. And just recently, just today, we posted latest water quality information. So if you go to cityofportsmouth.com, you can go to the water system, and you can get all the data, the latest data on PFAS levels in the water. And again, you know, there's detectable levels, but all below the current New Hampshire standards. And you know, the Pease water has been treated since 2016, and since 2021, we have the advanced treatment, which is carbon together with resin. So just wanted to clarify that. Thanks.
Thank you. Brandy, I think you had some more questions.
There is one more. It is, where can we get repeat testing that is performed in the same manner as we had in the study? My levels were much higher than average. You mentioned a lack of standardization. I would like to get the same type of testing, ideally paid for by the Air Force.
Well, to the last point about being paid for by the Air Force, I don't know that I'm qualified to answer. And I will say that the testing and Chris just said that the testing that was done in the Pease study, I'm pretty confident was done in our lab at CDC. And I'm quite confident that no one else is using that assay. And so this is, you know, there are commercial labs, which I know have looked at our assay and are following it, but I just talked to the head of our lab on this and asked this exact question really. And they said, you know, every lab is, you know, they may have the same machine, but they might do the assay differently. Is this going to cause, you know, I wouldn't expect it to cause huge differences, especially in long-lived PFASs, right? I wouldn't expect massive differences in your level, but nonetheless, there might be differences. And this is why the test-retest thing is so important, right? So if you had a level of 12, of the 4 combined, and you got retested on a different assay and you got a level of 10, was that your exposure reduction? Was that the difference in testing? You know, these are the questions that I think we want to be careful about, because we don't want people to say, oh, I'm doing great, I got my level from a 12 to a 10, when it's just different lab techniques.
If I may comment on this, Dr. Bernstein.
Sure, Marion, please. Yeah.
So I think you know, I agree with number of points that you have made, but I would like to also mention that you know, the original New Hampshire biomonitoring was conducted in 2015-18, and 3 different labs participated. right? CDC lab, Antonia Calafat lab, SGS Access, the lab in Canada, originally Access, Vancouver, and then New York State Health Department lab that that's PFAS. So while they did measure different PFAS and everybody used a different method, there was a pretty good agreement between the results and some repeated results that the labs made. I think that, you know, total standardization for like clinical testing, like you mentioned for thyroid hormones, I think has not happened, you know, in the field of lab testing for chemicals. And we've been testing, you know, stuff from 1970s, right, on different chemicals. And I think it's very difficult to achieve with the clinic, with the private labs, laboratories and companies that we have included. That doesn't mean that shouldn't be attempted, right? What I'm saying is that the methodologies that those labs used and the protocols that they use, you know, are fairly, you know, reliable. And I think that the repeated measurements, like you're saying, if somebody measured 12s, if that same sample is measured by SGS Access and the same sample is measured, like for example, in New York State Health Lab, I think that those results would come close. What we need to achieve, I think, on that end is that, you know, there needs to be a little bit more of intra-lab testing, that the public is comfortable that those different labs, you know, provide us the similar results. So in European Union and in Germany and other countries, you know, have kind of legislated that kind of process, that measuring chemicals lab have to participate if they want to get their certification. They have to participate in inter-lab blind comparisons of, you know, getting results, and those results are published kind of biannually in Germany for dioxins, PCBs, and other chemicals. So that may be a way of getting to, you know, if not necessarily standardization and everybody using the same method, which is very difficult to achieve, but to provide that kind of transparency and result of testing when the labs would kind of willingly or if not willingly, that they would participate in that kind of inter-lab certification program.
Yeah.
So I have a few questions. So from a clinical practice for physician pediatrician.
Come closer to this, I'm sorry. Sorry about that.
So I guess my question is you talked a lot about pediatric dyslipidemia. Is PFAS exposure a risk factor for either primary or secondary for pediatric dyslipidemia?
Remind me of your name, please.
Ursula Preston.
Thank you. So I don't know that we have the data in children, so I think the evidence on dyslipidemia is in adults. I could be wrong about that, but I don't know that I've seen studies specific on children. Now, the multi-site study is going to look at that. And I think one of the compelling things about the multi-site study is it's not just the history of cholesterol, we're actually measuring cholesterol. And so my hope is that we'll learn more. Many of you are very well informed, and I'd be happy if someone say, yeah, there's a great study that was done in kids in PFAS and cholesterol that I might be aware of. You know.
Well, but as far as it being a risk factor,
Yeah.
we know that PFAS is inherent in the majority of the United States population.
Yeah.
We know that pediatric dyslipidemia is a silent disease. So if you have a 9-year-old female that presents to your office
Yes.
without any risk factors,
Yes. So
no familial or obesity,
they should be screened under routine screening protocol. So every child in the United States is recommended to have cholesterol screening in childhood, bar none. Right, so that is a routine part of pediatric practice, standard of care. Some starting, you know, usually it's age 8 or 9. So if that doesn't happen, then that's not standard of care to my knowledge. Now, if they have a PFAS exposure, could you push it up a few years? Is there a family history of high cholesterol? Is the child overweight, has an unhealthy diet?
no other risk factors.
No other risk factors. It's still routinely recommended.
Particularly because, again, we're looking for a variety of things that can lead to high cholesterol, including PFAS that would be otherwise undetected that could affect that child's health across the life.
So then is PFAS a risk factor?
We don't know in children, to my knowledge, yet clearly.
Because actually, before I came, I just noticed a study online that was just published about pediatric dyslipidemia
Yeah.
for pediatricians by the Yale School of Medicine. And it went over the primary and secondary etiology.
Yeah.
And in the entire study, they did not list environmental as an etiology, primary or secondary.
And so my hope is that we'll get, my hope is that, and again, I'm always happy to learn. Like, I do not pretend to know everything I need to know. And I'm very happy to learn if people have studies that they've seen on, childhood lipids and PFAS exposures. But, I think one of the things the multi-site study, my hope is that we'll be able to look into that. It depends on the sample, right? So not a lot of children do have high cholesterol. And so depending on what we see in the cohort, we'll see if we can get more insights into that.
Oh, one more question.
Yeah.
What is the responsibility, or if there is one, of the state? So for example, does the state have, because in your clinical practice guidelines toward the end, you list that the state may be involved because they have a lot of information. It was toward the end.
Mm-hmm.
So my question is should the state inform clinicians? Like in the state of New Hampshire, 32% of municipalities in the state of New Hampshire have contaminated drinking water, which is pretty high.
Mm-hmm.
So what is is there a responsibility of the state in informing physicians, or giving physicians a list of all the towns that have contaminated drinking water? So that at least when when a mother or when a parent presents with their child, they're not going to know what questions to ask.
Yes. So I can't speak to the responsibility of states, right? So what I can say is that I have spoken with, so our connections to CDC are with state departments of public health. And I will tell you that in many states, and I put New Hampshire on that list, the state environmental health officers are very aware of these issues and have been pushing out information. And we want to make sure, to your point, that providers are aware and like we said in our information coalitions, like understanding what the sources of exposure are in the community, including water, food, et cetera. Like that is very important information for providers to know, both in the decision around PFAS testing and or related to what you're going to do with a test or even without a test about potential disease risks. So the connection you make is absolutely right. Rosal?
Yes.
Yeah. We need to make sure providers are aware of that information. Our connection to that is through public health departments. And again, this year, we're making a concerted effort to work with physician organizations and trying to connect those dots because they're often not connected, as your question suggests.
And if I could just add, there is a 2017 systematic review that compiled information from other studies looking at PFAS effects in children, and dyslipidemia was one of the facts where they did see association between higher levels of PFAS exposure and greater likelihood of dyslipidemia. But I think there were not all that many studies on kids, so as Dr. Brinton said, multi-site study will provide new information too.
I mean, just as an example of the challenge of the limited data. So I don't know those studies, but the first question I would ask is one of the sources of PFAS exposure is grease-resistant coating in fast food. So one of the sources of high cholesterol is eating fast food. So if we're doing an associational study, was that PFAS exposure from water? Do we know it's from water? Or was it from a source of exposure that might have been involved with an unhealthy diet? Right? This would be something you'd want to know before you definitively say, yeah, that was the PFAS. And to your point, like longitudinal study can help do that, whereas cross-sectional studies, you can do that, but it's hard, for sure. Yeah. Other questions? Randy, are we okay? Okay, so thanks, everybody. I hope this was useful. I know I at least have one point of follow-up. Tara, can you do me a favor and grab an email address so I can follow up with Antonia?
Oh, yeah.
And I can't promise you I'm gonna come up with great answers, but I'm going to try. Because I definitely hear you. Yeah,
Will the slides be made available?
I think so. I generally do.
This is being recorded.
And I was right, it's being recorded as well.
I was just, you had mentioned that there was some information about private well testing. And so I just.
Oh, that-
didn't have that
that's fine.
information in
I
my
know.
ear.
Fine.
We had one, our New Hampshire colleagues help.
So when
Create
people
a
sign in, do they
contact.
give contact information?
So if people could leave their email address on the sheet of paper, we
I'll
can
give
make
you
the
my
slides
contact
available.
information and people can reach out to me. So again, I think Brandy put my contact information in the online chat for people that are online because I'm in the region. So you can always come to me and I'll try to direct you to the right source. I know if you look up there, we have multiple ways to contact people, but if you come to me, I can get you to the right place. And for the people in the room, it's online, but it's hard to say in the room. But my email is T as in Tara or Tom, V as in Victor, the letter S as in Sam, and the number 4. I know it's funny, at cdc.gov. You can reach me that way. And my cell phone number, if you like that, is 703-505-7559. Again, 703-505-7559. That's my cell phone. It's with me all the time. You can see. So you can text me or call me and we try to get back to everyone as soon as we can. So that's helpful. And I'll be here after this if you want to check.
Thanks, sir.
Sure.
All right.
Hello, Chris, it's Brandy. Before you close, I would just like to say that due to the leak mistake that made all of our attendees show my name instead of their name, if you have a specific question that we didn't get to in the chat, or if you want more information on it, any of this, feel free to, since we can't reach out to you or most everyone because we don't know your name because it says mine, there's the different email addresses on the screen that you can reach out to. You can reach out to me. So I think the best one would probably be at this point, pfas@cdc.gov. That's an email box that we monitor. So if it didn't get answered and you need more information, please go there.
Are you closing the building down? Is that-
Supposed to leave at 8. I have
Yes.
to leave at 8.
Well, we shake your hands.
Thank you, everyone. So,
I don't know where the rest of you-
here they are.
Okay, thank you.
Yeah.